So, quick introduction about me. I'm the medical director of telehealth at VCU. I lead the digital health for American Medical Association. And with that, I not only take care of the telehealth platform, but the overall digital health journey for the patients and providers across the health system, as well as the national level with American Medical Association. So I've been really fortunate and lucky to be part of this group and be in front of you. So thank you. So I do not have any conflict of interest. So today we are going to be talking about, just a very common, like AI means so many things for so many different people. It's just like an elephant and seven blind men, for each one of them, it looks different. So I wanted to just kind of create a framework of, in a very easy layman term, what AI is. It's not only about, this, what you hear about this Star Wars technology of, machine learning and others. It actually has a spectrum. So we'll just go over very quickly on the spectrum so that we are oriented together. And then we're going to talk about, some of the business opportunities and opportunities of AI in healthcare. And then I will talk about two of the few of the research and the AI application I have done in my health system to show how really it impacted healthcare overall. And then we can talk more about it. And then I'm going to pass it along to Shanaka and the other panelists so that we can have more conversation. So AI, as I said, it's a spectrum of technology. It is not about only the latest and the greatest, machine learning and data science. It starts with, if you really think about this, and technologies which support human actions, technologies which mimic human actions, and technologies which augment human intelligence and actions. So, many of the opportunities actually lies around the automation, what we call as robotic process automation, where basically many repetitive things which we do, for example, clicking and ordering information about the weight of a patient to get the calculated dose of medication for the patient, can be easily done by the computers, and we don't have to do it. And lots of opportunities there because it is creating more efficient and effective way of delivering care. We'll talk more about some of the natural language processing. I'll show you a demonstration of something we are implementing at VCU Health, as well as a natural language processing and how it relates to telehealth. There'll be a video talking about it. And then we are going to talk a little bit more with the augmentation of human intelligence. And Shanaka is going to talk about the AR and how, School of Pharmacy is bringing AR in training of surgery. So moving forward, when we talk about AI, our mind always goes to the artificial intelligence in healthcare. But with what we think about artificial intelligence, and the AMA, we have a position statement saying this is augmented intelligence, where we are reflecting enhancing capabilities of human clinical decision making coupled with the computational methods and system. It's not about machine versus man. It is about machine plus humans. How can we enhance the effectiveness of both? So just a quick overarching information. This is a year or two old. So this is from McKinsey on the left side, what you're seeing, the bar, and what it adds up to. And they have calculated this, that there is a potential saving of about $270 billion. And they have divided into clinical operation, marketing and sales, risk, supply chain, and other operations. As you can see, it's mostly that repetitive automation work which needs to be done, and also the predictive analytics around this. Similarly, Accenture, if you really add all that information, it's again hundreds of billions of dollars we are talking about, and you will see this is robot-assisted surgery, nursing assistant, and others. All related to this, just kind of demonstrating that there's a huge potential of AI in making healthcare more efficient and effective. So moving forward, I think this is very generally used in telemedicine right now. Many of my cardiologist friends are using this technology where, the patient is able to transfer the EKG graphs to them for interpretation. And there is AI embedded in these technologies, which really helps the patient to know if they are in AFib or not. So this is something which is, I think many of you will know or might be using. So as we saw there, demonstration of a very small gadget which can be in the pocket of the patients, and if they have atrial fibrillation, they would know that they are in AFib and if their heart rate is high or not, and they can transfer that information to the cardiologist for titration of medication and further investigation as well. And most likely you already know about the Holter monitors and others who do the similar kind of things. But the great part of this kind of technology is that there is an AI behind the scene, which is kind of looking at that rhythm variation and determining if this is an abnormal rhythm or not. And there's a lot of technology behind that which goes here. This is very exciting. As you know, burnout is one of the major themes for physician practices and physician across the nation. It's one of the epidemic in clinical workforce. And natural language processing and documentation is the biggest burden on folks. With this last 2 years of epidemic, Nuance has come up with this a very ambient technology where they basically analyze patients' conversation and physician conversation and create a documentation just with the conversation. It's a very neat technology, and we are actually thinking about implementing it, and we just moved to Epic as well, and we have Nuance who will be looking into this a little bit further. So just as a demonstration, this is a 1.5 minute video here.
The Nuance Dragon Ambient Experience revolutionizes telehealth visits by securely capturing and contextualizing physician-patient conversations and automatically documenting virtual consults, all within Microsoft Teams. DAX alleviates burnout by reducing administrative burden and increasing efficiency while improving patient throughput.
You tried anything for the symptoms?
I have. I tried ibuprofen. I've taken my allergy.
Audio for DAX is securely captured through Teams as part of the virtual consult, with no additional hardware or software required, and physicians can be onboarded and trained remotely. The entire conversation is recorded and diarized with high accuracy, so nothing is missed, lost, or forgotten. Focus remains on the conversation, as relevant information from both what the physician and patient say are automatically summarized and added to the clinical note, eliminating the need to re-enter information. Beyond documenting the consult, an integrated virtual assistant allows physicians to conversationally interact with the EHR and complete tasks, further reducing burden and eliminating rework.
Hey Dragon, order the medications as mentioned and send them to the pharmacy. And I'm gonna have my office call you in a week to see how you're doing.
AI automatically converts the conversation into standardized structured notes that go through a brief quality review process to check for accuracy, omissions, and appropriateness before being delivered for signature directly in the EHR. Nuance DAX for Microsoft Teams promotes a better telehealth experience for both patients and providers by powering virtual consults with clinical documentation that writes itself.
So this is not only the Nuance is doing it. There are so many other companies who are doing it, and I think we have come to a point where we are very close. We are very close of making this available to most of the physicians, and hopefully, this is going to reduce burnout. So, after wanted to show what is happening in the environment and in the ecosystem of the telehealth and how it interacts with overall AI. I also wanted to kind of show that it's not only about the AI which can be developed by these big companies, but also can be created internally as well. So this is one of the publications we did, and we talked about how we created predictive analytics to decide strategically on, how do we manage patients who are coming to the ED, and predicting how many beds, how many nurses, how many physicians, how much resources will be needed based on predictive modeling. So here what we are seeing, here what we are seeing is the problem statement. Our internal medicine patients in 2015, 2014, 2015, we're admitted to these 19 different units for house staff as well for hospital medicine services. And this, as you can imagine, really creates a bad experience for the teams as well as for the patients, because they have to walk through all across the different floors, different towers to see the patients, wasting valuable time and again, the coordination of care. And this was a big issue for us because of the burnout. What we also saw that only 60% of the patient admitted to house staff got to bed in the house staff dedicated unit. We created simulation model to really understand and dive deeper into what is really happening and why are we not able to cohort all the patients from medicine into certain units, and so that we can enhance the experience and enhance the throughput. And here's the video which was created, and the background is a lot of predictive analytics going on to understand what if. We created this simulation model based on the real data from the EHR and simulated it with the patients to see how does the overall operations presently look. Once we had good confidence of how the patients are being admitted to which team and how they are interacting, we had a good confidence that we can create what if situations to ask the questions, which is, how many teams, where should they go, what should be the algorithm be, and others. So here what you're seeing is the teams rounding in the morning, and you can see that there's so much of redundancy and we are moving all across the health system. And I have flattened this simulation significantly. This is several towers we are talking about here. So as you saw that it really visually gave you that there is a lots of waste here and there's a very little value added time, and how we can then move forward and create what if situation. What we implemented some of the solutions which we found from the predictive analytics, and in 3 years later, what you saw that 60% of the patients were only in the medicine designated unit. Now more than 95% of the patients were in the medicine designated units. We also saw the length of stay of general medicine decreased. And as well as discharge before noon significantly increased. So this was a real success story, but this was done internally by our systems engineer and medicine staff.
Vima, we're going to need to transition very shortly.
Oh, well, so no, I'm all done. I just wanted to kind of say this, that, the Gartner hype cycle, we are at a peak of inflation at this point of time, and it's not always that the AI is right, as we can all remember from IBM's Watson for Oncology called for $62 million and unsafe treatment recommendation. They were canceled. So certainly we need to be very careful. So I'm going to stop there. And certainly happy to take more questions at the end of it. I'm going to pass it along to Dr. Shanaka. Please go ahead.
Thank you, Vimal. Can everyone see my screen?
Yes.
Okay. All right. So I'm going to tell you guys a story. This is something that actually happened here. And it's kind of interesting when your basic science research stumbles across an application that can be used in surgery. You see two people here. This is Mr. Castillo over here, and this is Dr. Dan Tang. Mr. Castillo had a very complex type of tumor in his heart, and Dr. Dan Tang needed a new tool to figure out how best to go and do the surgery. And both of them are wearing HoloLenses, and they are actually looking at Mr. Castillo's heart right now. All right. So what did we set out to do? We wanted to create patient-specific virtual 3D models that are taken from CT and MRI scans, create an AR environment for visualization of these models, for surgical planning, for use during surgery, for surgical training, and also for medical student, resident, and patient education. The final application can be used in collaboration between an unlimited number of users, meaning distance and telehealth are all possible. And the tool also allows surgeons to collaboratively develop innovative surgical procedures. What is the current state of the field? If you look here, this is Mr. Costello's heart, and this is what Dr. Tang had to go by. You are going through these stacked planes of images, trying to recreate the 3D structure in your mind. And the tumor is a little bit of a thickening on the midline of the heart. And for anybody other than people like Dr. Tang, it's impossible to look at this and understand where that tumor is. So what did we do? Before we get to that, I want to give you a little bit of definitions, because this augmented, virtual, and mixed reality, all these things are coming out now. If you ever watch Avengers Endgame or Iron Man, what Iron Man sees where virtual objects are superimposed on the real world is called augmented reality. On the other hand, if you see in Ready Player One, that is virtual reality. You are immersed in a world that is completely artificial. And for anyone who has played Pokemon Go, where you're looking at the real world through a camera, and there you see virtual objects like the Pokemons, that's called mixed reality. And within these three terms, because the terms keep evolving, we use a common terminology called XR, or extended reality, that applies to all these three areas and any future areas of augmented reality coming down the pipeline. So let's take a look at this solution, right? Not only did we build this, but this is a model that the surgeons can interact with. And I'm going to run this. So you have a little bit of the patient's history there. You can move the model around, including superimpose it on the patient itself. So you know how the heart is placed and how the object that you're trying to get to is situated within the patient. And
hide left ventricle.
And that brown mass that you see in the middle is actually the tumor.
Left atrium. Hide left atrium.
As you can see here, the surgeon can game different scenarios to approach the tumor before they even open up the patient.
Show left ventricle. Show right ventricle. Show.
And I'm going to continue in the interest of time. And of course, using this tool, the surgery was a success. Yeah. They took out the tumor and they essentially recreated the material that they took out, and everything worked out fine. And it's an interesting story because this...
My name is Aldrin Castillo. I'm a college student from Fredericksburg, Virginia. Nearly a year ago, in February of 2018, I got open heart surgery here.
Yeah, and Mr. Costello was in a difficult situation because of where his tumor is and the fact that he has a tumor. He's not a candidate for a human heart transplant and a total artificial heart transplant, meaning the only thing that they could have done was put the person on palliative care. But what I want you to understand is the
nurse in the near future, and maybe
that actually...
Right now I'm taking some prerequisites for the nursing program, and so I plan to be a nurse in the near future and maybe eventually a physician assistant. The ultimate goal is to have a family. So Dr. Tang made that possible by keeping me alive through the surgery and everything going well.
So the guy who would have been put into palliative care now through a very innovative surgical procedure had got a new lease on life. And the last I heard, he has joined a soccer league and he's doing really well. Now this application can be, there's a lot more in this video and you can go and look at it if you're interested, but cardiothoracic is only one possible application. We've done so many with this type of technology since then. We've looked at kidney cancers, we've looked at aneurysms. We are working with other groups looking at hernia, and so many different areas. Right. So where do we go from here? So we talked about surgical planning. Well, our ultimate goal is to use this intraoperatively in the sense that surgeon puts this on and they can superimpose these images directly on the patient. So what you see here is, I would say what you call the surgical dummy maybe. And all these structures that you see here are not visible. They are projected onto the dummy through the platform that we are using. So in a surgical sense, you can actually stay in front of the patient and actually see all these internal organs and where to make that first incision, how to approach that tumor before you even open up the patient. I'm going to stop there, and I want to tell you where this lines up with telehealth, because we are already testing this platform with different groups. There's a group from Brazil that we are working with for shoulder replacement surgery. And we should have a completely online AR-based conference happening where different groups of surgeons from across the globe can get together, wearing the same set and see the same image in front of them and game through different scenarios and tap into each other's expertise in how to get the best possible result for their patients. I'm going to stop there and happy to answer questions at the end. And thanks, Matek and Bill, for inviting me, and Vimal for inviting me.
Thank you very much. And now we're going to transition to Dr. Tyson's going to talk about HealthWagon, essentially applying this from the university setting into a free clinic, very practical application. So Dr. Tyson, go ahead, please.
Okay, we're going to share our screen here. I want to talk to you about the HealthWagon. The HealthWagon, we're in the far southwestern portion of Virginia. And so, we're using AI and virtual reality as well, although we're very rural. But just to give you a little bit of history about the HealthWagon, the HealthWagon's mission is to provide compassionate quality health care to the medically underserved here in the mountains of Appalachia. In the beginning, we were actually started by Sister Bernie Kinney. She was actually a Massachusetts Catholic nun who came to the region. She was actually in Tanzania in those early years, and the diocese at Richmond requested that she come here, and because of the severe poverty that was in the region and all the significant healthcare disparities that also existed as well. So here she kind of, and what the HealthWagon is, we are the oldest mobile free clinic in the nation. And we have 4 stationary clinics, and we also have mobile health. We are most known for our mobile health services that we offer, to the region. Last year alone was our biggest year that we've ever had, and that was due to COVID. We had 35,000 patient encounters that received free care. We had a very robust response to COVID as well. But here, Sister Bernie is in this picture here. She was actually a hero to the people here in our region in those early years, because she was actually incarcerated on the federal level for actually impeding traffic in one of the coal mining strikes, and it actually made the New York Times. And they said with the mobile unit that she was actually impeding traffic, and knowing her spirit. She probably may have not been, but she was jailed, and she, and they picketed the court, actually the federal building here. But she came out as a hero to the people. And this is just one of our very first older mobile units, and that's actually me down there in the left-hand corner. I've been here for 30-some years at the HealthWagon. We are a nurse-managed clinic as well, and I'll kind of breeze through these first parts here and get to how we also use what our others have been talking about here. We're in, some of the poorest areas in Virginia, Lee, Scott, Wise, Dickinson, Buchanan, Russell counties, serving our patients. And it's just, however, our patient encounters have grown over the years. This is our service area, and you can see that we're in the tip there of Virginia, very mountainous area with a lot of inherent problems, a lot of poverty, and all the disparities that come along with that. And there's just a great divide, in Virginia, the rural-urban divide here, lots of healthcare disparities. We're the belt for everything. We're the cancer belt. We're the the kidney stone belt, the cardiovascular belt, this, lots of healthcare disparities. And I'll not labor there. We'll get to this over here. I need to jump to slide 34. Rachel, help me with that. We live in one of the, as you can see here on the right, one of the prettiest, I say the prettiest area, of Virginia here. But I think, coming from the area, we have to be very resourceful. We have to embrace innovation. And Health Wagon has always been at the forefront of that. You will see our drone here. We actually worked with a group. Flirty actually had the drone. We worked with Virginia Tech, RAM, NASA Langley on this, and we did the first ever FAA drone delivery, in the United States as well. And here's just some more pictures from that. We did that in 2015, and here is the Governor Terry McAuliffe that was here doing that. We are the highest utilizer of telehealth, like in Virginia, with our wonderful partner, University of Virginia Health Systems and others as well. We use telehealth, for pretty much everything, and have done so for 28 years. We have been doing telehealth as well, and we all know the advantages of telehealth, and telehealth has really risen to the forefront with the COVID pandemic. This is some of the utilization that we do with our telehealth model. Screening. We have a retinopathy camera that we use as well as all the different specialties that we have as well. And as you'll see here on the right, that's me with Dr. Tracy Crutsby. We're doing the first ever telecystoscopies in all the world over telehealth. And so we will be doing those locally. We have really low rates of bladder cancer here, and that doesn't translate to the high rates of smoking that we see in the region. And so we know that they're just not getting done. And so, being a free clinic, this is all about, removing these barriers. But there's some of the other uses that we have for like our telehealth as well. And I think this is, one of the most important slides that we have here, because like the Health Wagon, we do use the artificial intelligence with our Amwell carts. We're able to link up with any specialist about, essentially anywhere in the world that we would need to. We have remote stethoscopes, otoscopes, dermoscopes that we use, ophthalmoscopes. We actually, on several occasions have saved the vision of, people by able to get a retinal scan, immediately back to the University of Virginia, although, there's 6-hour travel distance in between us, and save people's eyes and get them to the retina specialist by, knowing right away. And the Amwell carts are just absolutely beautiful. They can turn, on a 360, they can capture images. We also use like the EKO stethoscopes, and that we're able to do the EKGs, and it has automated like murmur and atrial fib detection for us, which is very to a audiologist. It amplifies the sound up to 32 times, which is, and we can also use like earbuds. These stethoscopes are just amazing. But one of the things I'm most proud of is this mobile ODT colposcope. I had to train to do, and my friend Paula, or my colleague Paula, we actually trained to do colposcopies because we had to. I remember attending the funeral of an individual. He was speaking about, his daughter was 28 years old, and he was doing her eulogy at the funeral, and she died unnecessarily of, HPV. She didn't have insurance. She was diagnosed at about 18. Came back into the healthcare system at about 26 with abdominal pain. She'd had an abnormal pap when she was earlier. No insurance, hadn't got care. And he was, it was so sad. He was, talking about how he had to, he was praying in those last days of her life for God to just go ahead and take her, because she was in so much pain. She was, she'd never been married. She didn't get to have a family, and her life just taken unnecessarily away from her. So we learned to do colposcopies after that. And so with this, we are using the AI with that. We can assess normal and abnormal cervical images that we find, and with accuracy of an expert. And we can run the AI algorithms with this, and they go back to a portal or the app, and we can receive like emails, normal, abnormal. We do these in our partnership also with the University of Virginia. So they allowed us to come there, and train many years ago. But now I attended the Hershey conference and seen this mobile ODT and said, we've got to have that. And University of Virginia was so good in providing that with us. They've been so wonderful. But we also, do point of care ultrasounds, and, actually we're breaking ground right now on a dental clinic here, because one of the things I didn't tell you about was we've always did the largest healthcare outreach in the United States. And probably a lot of people in the room have been down to our RAM event that we had for 20 some years, and dental is a big need. And so we're doing like 3D printing, of dentures as well. And we'll also, in our new dental clinic, when we get that up and going, in the next several months, we'll be using lasers to do dental caries, so that you don't have to have that injection and so forth anymore. So a lot of good things happening, even on the front of dental as well. This is just some more pictures from the telecystoscopies I was telling you about. And so that was pretty much the big part that we had, as well. This is one of our partners here in the radiology. We actually send the images back to a PAC system, back to a radiologist that will read for us. So I think that highlights pretty much how, we've been using, telehealth and ultrasounds with the Philips has been a great partner as well. But that kind of sums up how we have been, using AI in a rural area. And if we can do it, I would say anybody can do it, because we're in a very much a low resource area. We don't have a lot of resources at all. So we're always looking for that, innovation, and how do we bring that home to our patients and save lives and turn around the horrible trajectory of such significant healthcare disparities here. So just wanted to share that with you.
Thank you very much. And we have maybe time for one or two questions. If you want to type them in the chat, or I'm not sure if people can unmute, that may not be possible. Do we have any questions? I'm not seeing anything in the chat. I certainly have one. So wonderful things. I was really impressed by the hundreds of billions of dollars potentially in efficiency of using AI and VRs. How do we move this forward? What are the biggest impediments right now? It doesn't sound like, Dr. Tyson, you talked about, you're a free clinic and not a lot of money, but you're still able to use these things. So maybe cost is not the issue, but what do we need to do to move this kind of technology forward?
I can take a first crack at it if that helps.
Dr. Tyson, if you can just bring down the...
Sorry, Vima?
No, I was just talking to Dr. Tyson. If you can bring down the presentation.
Oh, I'm sorry.
Stop sharing.
Stop sharing. Okay. Rachel, I need to stop sharing.
Yeah. While Dr. Tyson's doing that, so I think one of the first things we need to do is start training our students not to be users of this technology, but how to build this technology. Because building this technology always used to be very difficult, not anymore. By training our students to build this technology, they can further bring the cost barrier down, because some of those subscription type of services, at some point, they can start raising prices. But as long as they know that competition from open source versions are available, that's going to act as a barrier towards them raising prices. So I think one of the biggest things we need to do is, educate our students about the availability of it, but also get them to, sorry about that, guys, also get them to start building.
Okay, any further comments on that? And I think we'll need to end the session.
Yeah, from the perspective, go ahead, Dr. Tyson.
I was just going to say, I would just add, collaboration is very important, because we are a free clinic, and so cost would have been an issue for us if we didn't have wonderful partners that, like the University of Virginia and others that reach out to us and make this happen. So we're very grateful for the partnerships and the collaboration.
Well, quick comment on that question, Bill. This is I'm talking from the perspective of not only as a physician in the front line, but also from the perspective of a university and a medical students as well, and what Shanaka has talked about. And so this is not one technology as you thought, right? This is a spectrum. This is creating a new venue of care. This is creating a new way of delivering care and caring for our patients. So there is a lot of lack of evidence base. What works? How does it work? Where does it work? And there is not enough information about that. It's at this point of time, this is Wild West. And it is more about show me the evidence question, show me that how, the AI as it is amorphous, AI is part of the technology continuum. Basically, how do you create the systems of care around the patient where they are and the needs they have. So there's lots and lots of work to be done, from education to training to developing evidence to implementing science and dissemination science to integrate it into the care systems which you already exist. It's a lot about the retrofitting. It is also a lot about how do we then enhance the education of our next generation, where they embrace and think about new way of delivering care. We are using the same stethoscopes more than 100 years ago. And we still use it, even though we know ultrasound works better. But it's about the legacy, which also comes into this overall conversation. So it's lots and lots of changes. And I think we are building the coalition together. So I'll stop there.
So thank you all very much. You have contact information for our speakers, and I think we're getting called to end the session. So thank you for attending, and we look forward to the future of Star Wars and telehealth. Thank you very much.